Okay, we're good to go. So hopefully y'all can see everything. We're recording. It's Tuesday, October 3rd, and this is our second lecture of 2 lectures in this unit, which is just trying to establish a foundational knowledge, working knowledge, vocabulary of pharmacology, pharmacokinetics, pharmacodynamics that we will need to draw from and build upon as we go. So this is really, really important material. So please be sure to do the readings, take notes as you go. Stop me if you have any questions. This is the last slide that we covered last week, and Dr. Fogger recommended that we pick up exactly where we left off. These concepts, we really want you to be encoding and encoding and encoding into very well-polished grooves in your brain. These are the 6 main neurotransmitters that are affected by medications we prescribe for the purpose of psychiatric treatment. So 3 monoamines, acetylcholine, GABA-glutamate. The drugs that we prescribe, and we're about to talk about how drugs change our bodies and how our bodies change drugs, which is pharmacodynamics and pharmacokinetics. The main functions of the drugs that we prescribe for the purpose of really, and this isn't unique to psychiatry, but some of the drugs we write block a receptor for a neurotransmitter. They may inhibit the breakdown of a neurotransmitter. It may prevent the reuptake of neurotransmitters after they've been released into the synapse. It might stimulate a receptor to do what it does. It might stimulate the release of other neurotransmitters, or make a neurotransmitter have a greater effect at a receptor, which is stimulating affinity. And some drugs are specifically, they act on autoreceptors. They do a lot of different things. So these mechanisms of action, when we talk about the mechanism of action of a drug, that's what we mean. Does it block a receptor? Does it block reuptake? That is a drug's mechanism of action. When you think back to beta blockers, the mechanism of action, well, it blocks beta 1 receptors, or blocks alpha 1 receptors. That's how alpha 1 antagonists work. That's how beta blockers work. Similar concept, just applied to these medicines. Pharmacokinetics. Kinetics means movement. Pharmacokinetics, drugs moving around the body. How does that happen? How does your drug, how does your body affect the drugs you put in it? For better or worse, our bodies adapt to anything we put in it. It's what we're designed to do. It's one of the main reasons why drugs inevitably, over time, lose effectiveness. Doses have to be increased, such and such. So I'm sure you remember from pharmacology last go around, and this will be review, so we're going to go over it pretty quickly. The stages of drug movement through the body. The first thing is it has to get into the body, absorption, by mouth, by muscle, through a membrane, sublingual, buccal, those kinds of things. The majority of the drugs that you'll be ordering are going to be PO, right? There are some patches for Alzheimer's, for ADHD. There are certainly patch options. There are long-acting injectable options for certain antipsychotics. But probably the most in a primary care setting, it'll be majority PO, and some IM, and again some. I think melatonin has a sublingual delivery system. The antipsychotics have the IM, like we talked about. Bioavailability is how much of the drug makes it into circulation, because to move around, which is the next step, drugs have to get into your blood. Oral administration is always going to be less than 100%. IV is always going to be 100% because you're putting it straight. As far as I know, there's certainly no IV psychiatric medications that we'll be talking about. So that's kind of a non-issue. But what would be the reason What would be the reason why a orally administered drug, 100% of it doesn't make it to the bloodstream? What's the reason for that? First pass through one of the oldest organs in our bodies. Exactly. So liver is probably the organ, one of two organs that we consider the most in the drugs that we prescribe for a variety of reasons. So hepatic functioning is going to keep coming back up, and we'll talk about that in a little bit. So you put the pill in your mouth, it goes to the stomach, out into the hepatic circulatory system, and then it makes its little way back into the blood. Long story short, you have a little bit, or maybe even a lot less, of the pill you put in your mouth ends up in your blood. So how does it get from your blood into your target cells? Several different ways. It might get into the cell through itty bitty little tiny pores, especially if you have ion. If it's a small enough substance, then it may actually directly get into the cell. It may have to travel through some sort of transport system that's going to be ATP dependent. You know about how the electrochemical gradient along all of your neurons work. It's a sodium-potassium pump. It's sodium and potassium being exchanged through little teeny tiny little ion channels. Lipid-soluble drugs, the majority of our central nervous system affecting agents, which is what we prescribe, are highly lipid-soluble, which is great because we need it to get in the brain. So that makes a lot of sense, that the drugs that we write, by and large, are very, very lipid-soluble, because that's where we need them to go. Into the brain, into the receptors on the dopamine neurons and the serotonin neurons, so on and so forth. Just remember that, and this is really because like dissolves like, and we have this is really a throwback to the phospholipid bilayer of the cell membrane of all of our cells, would much rather let a lipid pass through it than for water to pass through it. So that is really why lipid-soluble drugs are more able to make it into the central nervous system and into cells where we need them to be. An important concept is volume of distribution. From an osmosis standpoint, you will take a drug and it will sort of diffuse evenly until there is an even concentration throughout the bloodstream. It's not going to be concentrated in your shoulder and less concentrated in your right leg. It gets very, very evenly distributed, mixed thoroughly. These drugs being so lipid soluble, and they want to go into, they are attracted to lipids. They go in, and if there's a lot of lipid in the cell, then it may stay there for a pretty long time. So consider volume of distribution. How much space is there for the drug you are writing to go into that person's system? If you have two patients who weigh 120 kilograms, which I guess is somewhere in the neighborhood of maybe 260 pounds, something like that. If one patient is 5'4", and the other patient is 6'2", or 6'4", or 6'6", the adipose available in each person would be very different. So considering how much space there is, kind of free space, free lipid-soluble space there is for a drug to go in someone who's 5'4" and 260 pounds. How much drug is going to be available in the bloodstream? If there is that much extra space for the drug to get diffused out into, do you think that's going to decrease the amount of available drug remaining in circulation, or is that going to reduce the amount of drug still available in circulation when it's all gone out and kind of gets lost in this volume of distribution? It's a concept that you want to consider when you're working with people based on body habitus. And if someone were to suddenly gain a significant amount of weight due to whatever reason, well, and then it may seem like their medicine isn't working as well. Well, it's probably because there was suddenly a larger volume of distribution for the medicine to be distributed into. Because drugs that are outside of circulation don't have any activity. Drug needs to be in circulation, traveling around, getting to its target cells. It doesn't need to get lost in adipose tissue where it has no activity. So while an increase of volume of distribution or excess fat may require higher drug levels for a person, once the drug is discontinued, you also want to keep in mind, well, this person has sort of saved up drug unintentionally into this spare volume that has to eventually, through the concentration variant, it'll osmotically make its way back into circulation and make its way out of the system. So someone who's been exposed to a substance for a long time, it may get stored up and have an extended duration of action, even upon discontinuation. So things to consider when people's weight changes, that means the amount of drug you got to attend to changes in efficacy, changes in side effects. So speaking of distribution, drugs have to get around to everywhere and be free in circulation. Drugs like to attach themselves to protein. Proteins are just molecules that have certain shapes, and these drugs are just molecules that have a certain three-dimensional shape. You can look on Wikipedia and they'll give you the actual three-dimensional molecular structure of all these drugs. They're just different shaped things, and that's how they do what they do. They fit in different receptors that are shaped complementarily to them. They also just sort of attach to proteins that might be a complementary shape. A Dalton is just a unit of measuring the weight of a molecule. It's itty bitty tiny. You don't need to memorize this. This isn't Dalton. That's not going to be on the test. But just what we're trying to show is the relative size of albumin, the protein primarily responsible for maintaining the vascular tone is not the right word, but it attracts water and it keeps our plasma in our vessels where it needs to be. It's huge. Albumin's not just going to leak out randomly through the epithelial cells lining your arteries and your veins. It's a big old molecule. It's going to attract water, kind of like the way tree roots on the side of a hill keep the dirt where it's supposed to be. Albumin keeps plasma where it needs to be. Salt's itty bitty. No wonder, it's an ion. It can slip in and out of ion channels. Synthroid's bigger than salt, but look how much smaller it is than albumin. That's wild. Big molecules. They're big. They're not going to diffuse across a membrane. Osmotic pressures, you think back to chemistry, and if you need to review osmotic pressure and hypertonic solutions and hypotonic solutions, it all just has to do with concentrations and water's desire to exist in an even concentration relative to the things dissolved in it. You have your solute and then your water. Water wants to be even Steven with the solute. So water can pass easily through membranes pretty easily. Small things can pass more easily, but big molecules like albumin can't. So if drugs, which are attracted to albumin, if drugs are stuck to that, well, they're not getting in or out of the vessel. They're not going to be able to cross the epithelial barrier very easily, if at all. Big molecules will diffuse slowly, if at all. So drugs that are highly bound to proteins, very attracted to proteins, get stuck to them, are going to have a harder time getting out of the blood into the cells to be effective. So we just included some percent protein binding number there. Zoloft almost all of the Zoloft you put in your body is stuck to protein. So that little 1% that's free is the one that's available to exit the circulation, to get into cells, to act on receptors. Synthroid's really, really highly protein bound. Effects are not so much. So you can imagine if you have someone on a highly protein bound drug, and then you add on another drug that's highly protein bound, suddenly there is competition for those binding spaces. Somebody's going to get knocked off. So there is the potential, anytime you add a medication, that there may be competition for protein binding, which means there's possibility that something's about to have a lot more drug available to act. So side effects may suddenly increase. These are just things to think about. And we do not want to communicate that every time you add a drug, you have to change the levels of everything else, because that's not true. But we do want to communicate that more drug is not necessarily more. Adding something new may not necessarily be the right answer, because the more drugs you combine, the less you can confidently predict the response that you're going to have to any of them. Two groups. Can y'all think of the two groups of people who are at highest risk? They're at risk for low serum protein. Who might that be? Well, I guess there's more than two groups, but sure, the older people and younger people. Older folks, definitely. Yeah, absolutely. Alcoholics, which is for a couple of reasons you might think of. But yes, folks with alcohol use disorders, it's chronic alcohol use disorders. And people who are malnourished is another main group that we want to consider. You need protein intake to have it be processed by your liver to create proteins to maintain appropriate levels in the blood. So anything that makes your liver less efficient, anything that provides less building blocks for the proteins, because less serum protein means potential for more active drug. Because only drug that is not attached to a protein can get out and act or be metabolized and excreted. One of the reasons why we track weights on people. It's why we get liver panels. It's why we check proteins. It's why we check all these things. The blood-brain barrier is difficult to get into. Hard to get in there. The central nervous system. There are no loose entry points. Cells are very, very, very tightly attached to each other. They even call it tight junctions. Really doesn't want to let anything water soluble in. Fat soluble, sure. Water soluble, no. So penicillin, unfortunately, is highly water soluble. So if you want to get in the very unfortunate cases of more advanced syphilis, which is treated with penicillin. If you need to get penicillin into the central nervous system, you need to dose a lot of that to where osmotic pressure differences, just a concentration difference, forces penicillin across the blood-brain barrier. So people have to get multiple penicillin injections daily, repeatedly, to get the concentration of the chemical enough to where it actually gets where it goes. There are some drugs that we will talk about later that try to compensate for some of the protective mechanisms that the central nervous system has, that your brain has to keep drugs out of it. But just generally, the take-home point is what we write, is highly lipid soluble, susceptible to changes in volume distribution, and the only drugs that can get into the brain where we want them to be need to be, ideally, lipid soluble, and they need to be not attached to a protein. Because drugs that are bound to a protein in this little chart, they're not going to get out of circulation because they're stuck in the blood because they can't get through the epithelial barriers. It's attached to things that are too large. Now, a water-soluble drug, if it's not attached to a protein, can get out of circulation, but it'll be stuck in third space, just where loose water and lymph and random things are. But it's not going to be able to get across the blood-brain barrier. It has to be a free, unbound, lipid-soluble drug. That's how they get around. But then how does our body get rid of substances? Metabolism. It has to be converted some kind of way to an inactive form, maybe an inactive metabolite, or converted, thanks to the liver largely, into something that's water soluble that can get kicked out by your kidneys and not brought back in. So kidneys, talk about in just a second, is the other particular organ of interest that we monitor very closely. In your previous classes, how much do y'all talk about the CYP or CYP450 enzyme system? Did that come up a good bit? It came up a lot. Good. Good. Start, for those of you who I've recommended you make a little chart, a piece of paper of the drugs, maybe drugs per category. SSRIs, just start there because that's a really easy place to start. When you're writing down indications, starting doses, contraindications, the ideal patient for this drug, make note when you're reading through Stahl if the drug has a significant effect on CYP450 pathways. Here's some of the main ones. 2B6 is another one, but 1A2, 2D6, and 3A4 of the CYP enzyme system probably metabolize the majority of the drugs that you will be writing, assuming they go through a CYP system, because not all drugs do. But liver disease, chronic or acute, anything that's going to reduce hepatic efficiency, or competing drugs, because you only have so many enzymes in the 1A2 pathway. If they're totally occupied by nicotine, for example, from someone who's smoking cigarettes, and all of your 1A2 enzymes are occupied, then it's going to be really slow breaking down anything. If the patient is taking a medication that induces an enzyme, and there really aren't very many medicines that we write that induce. Some seizure medicines do, and they induce pretty much every enzyme. And some of the tuberculosis treatments. So, really, unless you're dealing with patients who are being treated for tuberculosis or who are on Dilantin, then you don't really need to worry about inducers. A substance that's an enzyme inducer means it's going to increase the activity of the enzyme. If the enzyme is breaking down medicine too quickly, then your drug level is going to be lower than anticipated. There are way more inhibitors than there are inducers. So while you really want to encourage, while you're studying these medicines and getting used to these medicines, that you start making note of how the drugs affect the CYP450 system, okay? Because a lot of them inhibit 2D6, and a lot of them are substrates of 2D6. A substrate of an enzyme is just the thing that the enzyme acts on. It's what the enzyme processes. I think an analogy I've used before is, it may have been in this class even, is if the Keurig machine is the enzyme, if the Keurig is the enzyme, then the K-cup is the substrate. The K-cup is the thing that the Keurig machine works on, right? Paxil is a 2D6 inhibitor. Prozac is a 2D6 inhibitor. Wellbutrin's a 2D6 inhibitor. Luvox inhibits a lot of these things, 1A2 and 2D6. That's why you don't see Luvox written a whole lot, just because it makes it harder to, predict effectiveness of doses of other medicines. That's why you don't do that too much. So for our purposes, the main thing we're concerned about is CYP450. And again, there are additional sites of metabolism about which we are not as concerned. Signs and symptoms of liver disease. The labs that you would check. AST, ALT. And that can indicate acute liver injury. Over time, AST, ALT may actually normalize or be low just because there's not enough remaining healthy liver tissue to be releasing the enzymes therein. Bilirubin has to get conjugated by a healthy liver and excreted. So if there's not a healthy liver, that'll go up. Albumin will go down. Consider the education you'd provide a patient. Like, don't drink and take a lot of Tylenol. Tylenol PM is not a benign substance. You may work with folks that happens all the time. What you're trying to do is predict as best you can the result that you'll get from a certain dose of the medicine. So other substances, hepatic insufficiency, all of these things can affect your ability to predict. Most drugs, after the liver, ideally, will process something, inactivate it, process it for export. Your kidneys will get rid of it. When you think of a psychotropic medication with particular implications as far as kidney functioning, what do you think of? A drug commonly prescribed for a mental health reason. Yay, thank you, Jake. Thank you, Jake. Yeah, lithium, because it's just an element. That's it. And once it's in solution, once it's in your blood, it becomes just a positively charged ion. Just like sodium, floating around. So your kidneys can't tell the difference between lithium and sodium. So your kidneys are just trying to maintain, based on what your hypothalamus and pituitary are telling your kidneys to do, is maintain a certain percentage of water to sodium balance. And then you have all this lithium in there. Your kidneys can't tell the difference. So if the person develops dehydration, or they join a CrossFit gym and they're sweating a whole bunch and not rehydrating sufficiently, well, physiologically they're going to say, okay, Let's hang on to as much sodium as we can so that we can keep all the water that is attracted to sodium. Well, suddenly lithium levels can be elevated significantly just because your kidneys think it's sodium. Half-life. All this means, and this is, I'm sure, a familiar concept to y'all, just means how long does it take for the breakdown and the export, the packaging and the shipping of drugs out of the system, how long does it take it, however much is in your blood, to be reduced by half. Prozac, it's 2 weeks. Effexor, immediate release Effexor, it's 3 or 4 hours. So there can be a gigantic variation in how long it takes a drug to get out the system. A steady state is essentially the amount of time it takes for a drug to reach a consistent level. How many half-lives does it take to reach a steady state? And it's typically 4 to 5. Let's say somewhere between 4 and 5 half-lives. The amount of drug that you lose is replaced by the subsequent administration of the drug. Because that's the goal. You want the blood level to be very consistent. But Prozac has a very, very active, a really active metabolite, norfluoxetine, that it can stick around for a long, long time. Venlafaxine does not. So you can imagine if someone were to miss a dose or two of immediate release Effexor, how quickly it will take them to feel very bad. Because if it's 4 or 5 half-lives, to get to a steady state, like an ideal steady concentration, that also means that 4 or 5 half-lives is what it takes for the drug to get essentially back to zero. So with Prozac, if the patient is maybe not as adherent to a med regimen, if you miss a day of Prozac, you are not going to notice it. Because it takes so long for the drug to even reach a noticeably reduced concentration. Effexor, yikes. With a half-life of 4 hours, within 24 hours, if you miss a whole day, then it's as though you have none in your system anymore. And that's why people have such difficult withdrawal syndromes if they miss venlafaxine in particular. And other drugs are similar to that. This is just a little chart that we wanted to show. Let's say the person is taking 1,000 milligrams. Adam's asking to know specific. No. We just want y'all to understand the concept of a half-life so that when you're reading in Stahl and you're looking at, because he'll tell you, he'll give you the pharmacokinetics of all these drugs. And if you notice, this drug's half-life is 24 hours, this drug's half-life is 36 or 48, this one's is 4. Whoa! You just need to know the shorter the half-life, the more you want to emphasize education related to adherence because of discomfort at accidental discontinuation. That's all we want. No, you don't need to memorize drug half-lives. But that's a good question. So this is just an example of lithium, which we go, for the most part, let's just say lithium's half-life is 24 hours, which is roughly true. And it makes this calculation a lot easier. So you can see, you give the person 1,000 milligrams of lithium on day 1. So their blood level, let's say it's 100% bioavailable. And voila. So you get up to 1,000 milligrams. That's how much you have on day 1. But then by the end of day 1, at the end of a half-life, which is 24 hours, let's say for lithium, that at the end of 24 hours, you're down by half. So you took 1,000 milligrams. At the end of a half-life, you're down to 500. That makes sense. Well, we're starting day 2, so you dose another 1,000 milligrams. You add that to the 5, well, voila, you're up to 1,500 milligrams. But at the end of a half-life, at the end of another 24 hours, your max of 1,500, well, that's going to be reduced down to 750. But on day 3, you're starting from 750. So you see how it builds a little tiny bit every day until after 1, 2, 3, 4, until by the end of day 4, when you're starting day 5. So that's why I say kind of roughly 4 or 5 half-lives. You're starting from 1,000 milligrams. So by the end of the day, you don't dip below 1,000 milligrams again. The amount that you lose in your half-life is replaced by the next dose. So you're at 1,000 milligrams, you go up to 2,000, while at the end of 24 hours later, you're back down to 1,000. So you're staying at that level. And if you continue to dose it, you would just stay at 1,000, stay at 1,000, stay at 1,000. But this is also to show the washout period. That after, let's say you don't take any on day 6, well then you drop down to 500 milligrams. Half of where you were. One day, the next day you're down to 250, the next day you're down to 125, and then by the end of 1, 2, 3, 4, you're essentially washed out after 4 days because we're going on a 24-hour half-life. So 4 and a smidge half-lives get you to a steady state, and if you completely discontinue the drug after 4 and a smidge half-lives, you're washed out. This is particularly relevant. We really don't do the education or the caveat you'll see on every drug commercial for an antidepressant is don't take for 2 weeks. Don't take within 2 weeks of a monoamine oxidase inhibitor. And what they're trying to protect for, they want to guarantee that washout period so the drugs do not overlap. And seems to be that a good number of drugs have a half-life that's roughly 24 hours. So if you give a 2-week buffer, then you are guaranteed that the drug has washed out. But again, we don't do MAOIs as a 4th or 5th line even medication. So it's really not an issue, but important to know regardless. So pharmacodynamics, drug changes, pharmacodynamic drug changes. What do drugs do to the body? We just talked about how our bodies accept, process, eliminate drugs. Now we're going to talk about what do drugs do to our bodies, and this stuff's really pretty important. What drugs do is they affect the function of cells. All diseases can be kind of broken down to be a cellular dysfunction. Well, the medications that we write to try to improve the experience of those disease states is to affect cellular functioning. And there's a few main ways that we do it that Stahl will talk about. I think it's pages maybe 35 to 51, I want to say, is what we had specified. But one of the ways that drugs can do that is to change ion channels. Now, a ligand or a ligand, depending on how you want to say it, I say ligand. You can say it however you like. A ligand is just a thing that binds. That's all it means. A ligand is a thing that binds to something else. So it may land on a receptor on an ion channel and make the ion channel more or less likely to accept an ion of interest, which when you're talking again about electric, the potential of a cell, you let sodium in, the cell gets more positive, it wants to fire. You let chloride in, the action potential gets more negative, the cell is less likely to fire. Think sodium-potassium channels. This is how lithium works. It affects, stabilizes the it stabilizes this exact system, the mechanism by which action potentials are returned to normal by altering the speed with which sodium and chloride enters and exits the cell. Probably the main way, the majority of the drugs that we write for psychiatric purposes are through this G protein linked receptors. And Stahl has some nice pictures in his book, but this is just a receptor attached to a pretty complicated structure, which is on, the cell wall. It's on the membrane of the cell, but it's a receptor that when a neurotransmitter, when a chemical messenger lands on this receptor, there's a 3-part protein structure on the inside of the cell called the G protein. And the G stands for you ever heard of the guanine? I think it's actually a substance that may be in some protein drinks or energy drinks. That is beside the point. But that's what the G stands for. And it's a 3-part protein on the inside of the cell wall. And when a chemical messenger or a ligand, a neurotransmitter, binds to the receptor on that, on the G protein linked receptor, it causes a change in the shape of the protein inside of the cell. So that's kind of how the outside chemical messengers can cause changes to the internal workings of the cell, is through this G protein linked receptor. Serotonin receptors do this. Dopamine receptors do this. Norepinephrine, beta-1, alpha-1 receptors. That's what they do. It's not as simple as they change the polarity of the cell and then it fires. No, it's way more complicated than that. Yes, I know y'all remember ATP and ADP and GTP and GDP, if y'all talked about that. Some of this is getting really more technically chemical than we need to. But yeah, these are very simple amino acids. These are very simple little critters that when exposed to another molecule changes the conformation of that protein. And the change of the protein's shape inside the cell allows it to interact differently with other proteins in the cell, with other enzymes in the cell. You can Google G protein linked receptor, and all of the really nice, enthusiastic chemists in the world have come up with great YouTube videos if you want more explanation than Stahl gives in those few pages. But the main, kind of the take-home point, is that these G protein linked receptors, the receptors on the outside of the cell, the proteins on the inside of the cell. And when it is linked up with that neurotransmitter, it causes the protein in the cell to look different and to act different. And that transformed protein sort of initiates different cascades of functions in the cell. It may activate an enzyme. It may turn ATP into something else called cyclic AMP. And that transformed protein may transform another protein. There are hundreds and hundreds and hundreds of these receptors on cells in our bodies, and each one does multiple functions. And they're not all fully understood. The main kind of fascinating part to this is that this is really the link between how chemicals, neurotransmitters released from a cell can cause the neighboring cell to behave very differently, to fire more, to fire less, to upregulate receptors, to downregulate receptors. It's how cells talk to each other. It gets the outside message inside to enact some sort of different operation. But this receptor is an example of one is involved in cardiac muscle, that norepinephrine landing on a beta receptor, which is a G protein linked receptor, results in the G protein changing its shape, affecting another enzyme in the cell, activating another enzyme in the cell. Voila, the next thing you know, there's more calcium coming in, and the heart's beating faster, and the heart's beating harder. It's a series of steps that have to occur. It's amazing how quickly they can happen. Another way that the medicines we write affect psychiatric disease is affecting transporters, kind of that reuptake. We've talked about that before. It may block the reuptake of serotonin or of norepinephrine. All of our SSRIs in DRIs, that's what they do. They may also, which is pretty amazing, get into the cell and initiate a cascade of activity that results in actually getting into the nucleus of the cell, so that the cell will create, it will produce different proteins. Kind of when I was speaking to a message into a cell to, we need to upregulate, we need more proteins to make more receptors, or we need to break down more receptors. These are the main ways that the drugs you will be writing affect and help people. These effects may be intended or not. They may be desirable or not. And again, your body will do everything it can to adjust to anything you put in it, for better or for worse. So we were talking about those G protein linked receptors at some length. So you can see how once a neurotransmitter lands on that receptor, that's kind of like flipping a switch, and then this whole process is unleashed inside the cell, and there is some action. Sometimes you want more of that, so you may prescribe a drug that has an agonist effect. If an agonist lands on a receptor, then whatever that receptor's downstream consequence is, that'll happen more. If you prescribe an antagonist, then whatever function that would result from activation of that receptor, that isn't going to happen. So it's essentially preventing that receptor from doing whatever down the road function would result. It doesn't mean the opposite happens. It just means the typical result is not going to result. So like we were talking about norepinephrine landing on those G protein link receptors on cardiac tissue, then norepinephrine is an agonist to that receptor. Lands there, you get the result. There are alpha-1 antagonists that could land on that receptor, but then nothing happens. Nothing new happens. Status quo stays the same. Prevents activation or initiation of that process. Affinity, and when we talk about antipsychotics, because this is a big issue in antipsychotics, is drugs will have a different attraction essentially, to certain receptors. They're not equally attracted to all receptors. Like Seroquel. Seroquel is more attracted to acetylcholine, to muscarinic receptors, than it is to dopamine receptors. Because these chemicals, these molecules that the drugs are, they're just shaped a certain way. And they fit in a bunch of different locks. And they fit in some better than others. So as we go, when we're describing the drugs and their wanted or unwanted side effects, a lot of that has to do with how attracted the drug molecule is to different receptors. Mirtazapine really likes histamine receptors. Really, really, really. To where at low doses, that's about all it does. All it does is block histamine at low doses. At higher doses, it'll actually block some alpha-2 receptors. So the drug at different concentrations will behave differently. And at any concentration may be more attracted to one type of receptor than another. And as you kind of start building your understanding of what receptors are responsible for what outcome, you can better predict, oh, well, at a low dose I can expect this response. At a medium or a higher dose I can expect this response. And it lets you be very precise with your dosing and predict good and unwanted results from that medicine. Drugs more or less want to be attracted to a receptor. It may stay there for a long time, or it may land and get off. We will talk about dissociation constants in the context of antipsychotics. But that's really a measure of the affinity for a receptor. And then efficacy refers to how much of a response does the drug get when it is on the receptor. So a drug like levodopa may have wonderful effects. It may be a very effective medication. It produces quite a substantial response. Partial agonists, this is unique from the others in that it kind of does a little bit of both. A partial agonist, and you'll think of Abilify or Buspar as having partial agonist activity, that where intrinsic activity is low, it's more than nothing. It's better than nothing. But where intrinsic activity is high, it actually blocks. So it has a little less of an effect from a full agonist, but more than what's available just naturally. And Abilify is a good example because in schizophrenia, you don't see it. Well, depending on where you work, Abilify is probably not the number one go-to for schizophrenia. But what's good about it is that the positive and negative symptoms that you witness in schizophrenia are related to maybe too much dopamine activity in some areas, not enough dopamine activity in other areas. So you can see how providing a drug that is capable of, it provides a boost of the baseline level of dopamine activity, but it's also going to slow down the areas that have too much. How great is that? Because just slamming dopamine, bringing dopamine down to get the positive symptoms under control isn't going to help the lack of motivation and the lack of energy and the isolation. So you'll hear us talk about agonists, antagonists, partial agonists. And that's what we're referring to. The receptor it's going to land on, is it going to cause that consequence of that receptor's activation, or is it going to prevent the receptor from being activated? The G protein link receptor, that may kind of remind you of clotting cascades, or the inflammation cascade, that it takes some action and then it causes the activation of one enzyme, which makes another protein available, which then cleaves off and produces another enzyme. Kind of dun 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 dun, this domino effect. Similar process to what occurs in the cell with exposure to that. Just another couple little comments, and then we will be finished with this material. We can handle questions. Therapeutic index, this is just the margin of safety. This is a measure of how much of a drug do you have to give a group of people to where half of them die, versus how much of the drug do you have to give a group of people to where half of them see a beneficial effect, see a therapeutic effect. So it's a ratio of how much does it take to be really dangerous versus how much does it take to be effective. So a very high therapeutic index means you have to give so much more to be dangerous than you're giving to be safe. A low therapeutic index means there's not much difference between a dangerous dose and a helpful dose. So you think of lithium. The range of effective to dangerous is pretty narrow. So this would be considered a risky medication because the therapeutic index is narrow. Other drugs with low therapeutic indices, you think of tricyclic antidepressants. They don't have as wide a window of safety. They don't have as wide a margin of safety. It doesn't mean they're all entirely dangerous, but it just means that if there are factors that might make the window even narrower, you want to be exceptionally cautious and probably not choose that agent. Benzodiazepines, in and of themselves, have a very wide therapeutic index. There is a big distance between effective and dangerous because of its mechanism of action. However, if you mix a benzodiazepine with another central nervous system suppressing agent, in particular alcohol, gosh, a barbiturate, yikes. Barbiturates have a much lower therapeutic index than benzodiazepines for reasons that we will discuss. So that's why interactions with medicines. Does the person have hepatic or renal insufficiency such that they probably have more drug in their blood than I would think based on their dose? Are they taking a medicine that could synergistically enhance the effect and therefore make the drug more dangerous? These are all things that you think about. This note of tolerance here is that as people adjust to the effect, and we can use alcohol as an example, that people can develop tolerance to alcohol, as we all know. But parts of the brain do not. The brainstem ancient structure that regulates breathing does not develop a tolerance to alcohol. So it is possible that a person can kind of sort of appear as though they are functioning with a blood level of 0.4. And by functioning, I mean they're awake and they're talking to you and they can walk. So if they take something, a benzo or pain meds, something that just puts them over the edge, parts of the brain don't downregulate those receptors. So they stay very vulnerable to their effects. The medulla is one of them. So while the person seems to not be as affected by alcohol, basic physiologic functions, blood pressure, respirations, they will, as Sabina said, stop breathing because their medulla hasn't developed the same ability to manage. So you always want to assess for substance use and other drugs that the person is taking, prescribed or otherwise, and consider factors that are going to influence therapeutic index. The neurotransmitters that we talked about at the beginning, and this is our last slide, this is something to be kind of studying and memorizing because we will apply this information as we go. I can answer you. Deborah, specifically, you're asking a question about competition. Help me understand what you're wanting to know.
I think I didn't. I mean, you just kind of went past it. I don't know if you just want us to make sure we understand competition as far as.
Oh, you mean competitive? Yes, ma'am. You mean competitive antagonist versus not?
Right.
Okay, sure. And really, in our medications, I want you to be familiar with the concept of competitive antagonism, and that's when you have a drug that not only will it block the receptor, it will get rid of anything that was already there. Come in and clear out the joint. Most of the drugs that we write are just antagonists. They're not necessarily going to kick out everything else. When I think of a competitive antagonist, I think of Narcan. I think of naltrexone.
Okay.
Oh, I misspoke. I'm sorry. I got alcohol treatments on the brain. Naloxone. Naloxone is Narcan. Naltrexone is Revia. Is another really good drug. But yet when you think that competitive antagonism, not a lot of drugs that we write, but maybe some more will come out. And we'll have the chance to talk about it, but for the most part, you just need to distinguish agonism from antagonism. Morgan's asking about, that's a good question though, so thank you. Morgan's asking about neural development and neurogenesis. Yes, that is testable material that is not included in this PowerPoint. But that is a good question. So this chart will help you a lot if you can commit this to memory. Because these neurotransmitters we're going to talk about at length in the disease process of depression and mania and panic and worry and schizophrenia. We're going to talk about these exclusively probably for the next, really for the rest of the semester, I would say. So we want you to start memorizing what these neurotransmitters, what they do, the effect that they have in the brain. And indications of too much of dopamine, indications of not enough dopamine, too much serotonin, not enough. All of these. Because to start just committing to memory the effect of these excesses and deficiencies of these neurotransmitters will help you, yes, Sabina, Parkinson's disease, as opposed to personality disorder. Good question, though. Because if you can track, and this is what Stahl says over and over again, that if you can track or if you can map the symptom to the responsible structure in the brain, the neurotransmitter in the brain, then you can improve the symptoms by altering the cellular function associated with that neurotransmitter. That's really what we're trying to do. So these are the main ones. If you'll kind of just start committing that to memory, then you'll be one step ahead when we're getting into the disease processes of depression. And that's where we're going to start, with major depressive disorder. It all comes down to chemistry. I agree with you, Sabina. So yes, anxiety, and obviously this is just a kind of a guide that if you want to print out and leave sort of next to you while you're doing all of your readings and listening to lectures and things. This is a very brief, abbreviated. So suicidal ideation, anxiety, some of these abbreviations here. SCZ is schizophrenia, nausea, vomiting, gastrointestinal, heart rate. You have, so under the right column, the left arrow, as I'm sure you would assume, means reduced heart rate, increased GI motility, increased perspiration, increased salivation. So there's just some symbols to try to put more information in one little spot to draw from. And someone had asked for a study guide, and yes, we're going to release that. We're going to release that a little bit later this week to try to help you focus, because we're getting some questions about kind of what to focus on. Yes, we're going to have study guides coming down to kind of help you as you're preparing for this exam. And yes, SATIC is very complex. As far as studying suggestions, the main things we want you to take from this discussion of neuroanatomy and physiology, as you're reading through the SATIC and through STAL, that you're gonna, I would encourage you to use the PowerPoints as kind of the structure, and then add on to this, kind of supplement the information from the PowerPoints based on the readings. And it is unfortunately too much information to talk about just in 2 lectures. So be on the lookout for the kind of guide that we'll give you, and that will help you know what to focus on from what you've read. But yeah, it's a lot, and it's just a lot. And it's very technical, and it's probably stuff that you haven't been exposed to a whole lot. Certainly not in the first year of the program. So just kind of pace yourselves, jot down notes while you're reading, map material from the readings onto the PowerPoints as much as is possible. Not only from this one, but the last week's as well, with structure and function. It's just a lot. It is just a lot. And it's very technical. But the better of a foundation you can develop really in this unit, because all of this information is we build on this. So use the PowerPoints as kind of the foundation. Fill out areas with static install as are relevant, and you will do fine. We're not going to ask wild questions from really random stuff in that static reading, but we're trying to help you develop just a vocabulary and just a foundational understanding of the anatomy and the functioning. But we're not going to ask you wild, picky questions that we didn't come anywhere close to talking about either last week or this week. So don't worry too much about that. Any other questions before we wrap it up? So be on the lookout for the little template. Be sure to read. Be sure to be very familiar with all the content in the PowerPoints. And if you have any questions, email me. Don't hesitate to. Don't you hesitate. So go eat a snack, go drink some water. That's a good thing to do. One more little comment is we still have quite a few folks in the PPF submission process, and I'll leave this recorded, is there are quite a few PPFs that were sent back for a few changes. So please be sure to go into your PPF. Everybody affected by this should have gotten an email saying your PPF has been sent for, I don't know what the terminology is, but changes are required, and please, fix and resubmit. So please be alert to emails from the PPF system if you need to go and make changes. They're not major, it's just that most people needed to add a collaborating physician's specialty if it wasn't specified, and the license expiration date. Not minor, and you can be creative with where you want to include that information. But please be sure changes are not required of your PPF, because you would have gotten an email. But that's it. So let us, we'll stop the recording, and if you have any questions, by all means, get it to us.